All right, thank you very much, Dr. Jones and Lasky. So I want to thank our previous speakers, Tom, Lena, and Amin, for doing all the science for me. So this part's going to be more practical. So we all know what the difference between monopolar and bipolar devices are. So here are my disclosures. It should not affect the talk here. So basically, we saw this slide, right? So we know that bipolar energy, you have two active electrodes here. So the nice thing about this, in an emergent case when you don't know if the patient has a pacemaker or AICD, you can use bipolar because all the energy flows right between these two types of instruments. We all learned that bipolar instruments use a cutting waveform, and it actually has a smart generator that's hooked up to it. So the active and return electrodes are in the instrument itself. The current is confined between the tissue that it affects. So the instrument, the active and the return electrode are very close, and it uses low voltage, 320 to 1200 volts. But what's different between a monopolar instrument and a bipolar instrument is you need actually vessel compression for vessel sealing or coaptation. So this is explained here. So with the vessel open, you see we get a lot of thermal spread. When we compress the vessel, we can seal the vessel, and we can actually change the molecular structure of the tissue to form a vessel seal. And we get this nice tissue effect. We get organized collagen to create that vessel seal using the cut mode in our bipolar instrument. And I'm going to show this slide here. So we need the vessel compression. So once again, the best mode to use for a great seal in bipolar instruments is the cutting mode. We get a continuous waveform here, and on these smart generators now that use the cutting waveform, right? So a question I get asked all the time by my residents and fellows is, how come when I activate the bipolar instrument on a vessel and you want me to double seal, it takes just as long to seal it again, right? We all use that all the time. So the answer is it's a delta change in resistance. So when we use our bipolar instrument, the tissue seals down, and we get this nice fibrin plug that forms, and then we get resistance, right? So it starts at a delta, say, 0, and it goes to a minus delta 50 for resistance, and we get that seal. But when you hit the instrument again, now you start at 50 resistance, and now you have to go up to 100 resistance. And sometimes it actually takes longer. So if you're going to do a double seal, we recommend you seal at one spot, then move your instrument a couple millimeters away and create a second seal. So once again, the principle here is we're using a cutting waveform, but if you use a coag waveform, it creates incomplete fibrin seal, and then you get incomplete coaptive coagulation. You get superficial coagulum that insulates the deeper layers, as Amin showed, and you get caramelization and sticking. So we want a very, very important point is bipolar uses a cutting waveform. So this is, I think, a very useful slide for you in your clinical surgery, right? So we all want to prevent lateral thermal spread. So if you looked at how to increase lateral thermal spread, you want to use a continuous current. You want to use high voltage and low compression. So we do not want a lot of lateral thermal spread. We want a low amount of lateral thermal spread. So we use a pulse current. We use low voltage, such as our cutting voltage, and we use a lot of tissue compression. So that's the key there. So on the right of the screen here, we're going to have the increased lateral thermal spread, and on the left of the screen, we're going to have the decreased thermal spread. And when we activate our advanced bipolar instruments, you can see the difference in the thermal spread. Very, very important concept, not only in the test, but also in your clinical practice. Thermal spread is seen with all electrosurgical instruments. We all know, and the number to remember, tissue death occurs at 60 degrees Celsius, and the range of thermal spread is between 1 to 3 millimeters, depending on the type of instrument you use or the manufacturer that you're using at that time. So be aware of the residual heat. So there are multiple different types of instruments on the market. Some use pure bipolar, some use a combination or integrated bipolar and ultrasonic instruments. And I know this is a kind of busy slide, but this is a great study that just came out in 2017. They looked at the function of an integrated instrument, which is a bipolar and ultrasonic instrument together, a normal advanced bipolar instrument, and a ultrasonic instrument. And they looked at recurrent laryngeal nerve injury in the pig model. Also in the pig model, they looked at 3 different tissue types: the liver, the muscle, and the thyroid tissue. So all devices were fired, and they had these couplers in the tissue about 1 millimeter apart. And what they really wanted to find out is what is the distance you need to stay away from the recurrent laryngeal nerve to prevent an injury. So very practical study if you do head and neck surgery. So when you compared these 3 devices, the liver tissue got the highest with the ultrasonic device. And Lena also mentioned that tip can get to 300 degrees Celsius. And we know that tissue death happens at 60. We know that vaporization happens at 100. So in this liver tissue, it got up to 115 degrees Celsius. Muscular tissue had the most effect with the integrated or the combination, and thyroid had the highest tissue temperature with the bipolar device. The key, I think, message in this paper was recurrent laryngeal nerve injury happened when the tissue was 1 millimeter, or the nerve was 1 millimeter or less away from your sealing device, no matter what device. If they were greater than 2 millimeters away, they did not see this in the pig model. But I still recommend that, we're looking at 1 to 3 millimeters. You should stay away, stay on the other side of the 3 millimeter range if you can help it during your operations. So other great advancements in surgery is when we're doing these advanced laparoscopic cases. 25 years ago, when advanced bipolar laparoscopic devices weren't available, it was very difficult to do Nissen fundoplications or sleeve gastrectomies because we didn't have a way to really tie these multiple vessels. And especially in colorectal surgery, looking at different devices that we use for dissection and vessel sealing. So in this study, they looked at 6 randomized controlled trials, including 446 patients, looking at different instruments. So they found that operating times were significantly shorter when an advanced bipolar device was used compared to a monopolar scissors. There's really no difference between bipolar devices and an ultrasonic device. Laparoscopic staplers, clips used for pedicle ligation in colorectal or in colectomy were associated with more failure than vessel ligation devices and cost more when compared to bipolar devices. But unfortunately, with all this evidence out there, there was not possible to demonstrate which instrument is the best for laparoscopic colectomy, so the jury's still out on that. So what are the pros and cons of advanced bipolar devices? Number one, definitely the pro, it doesn't require a dispersive electrode. So energy does not travel really through the patient, it travels through your target tissue. We use less voltage in the cut waveform. Energy stays between the jaws, and we can seal up to 7 millimeter vessels. What are the cons? With any other energy device, we have thermal spread from 1 to 3 millimeters. We also have current leakage, so don't be fooled if you have a bipolar device and the bipolar device cord is off the field. There is energy going through that cord. You have current going through that cord, so you can't wrap that cord over either a pacemaker or any other conductive device. You still need those cords away. And definitely a significant increase in cost compared to a simple monopolar instrument. So now with these new smart generators, you have this constant feedback. They have near real-time impedance feedback, so that current that goes through, that cut current, is now read back to the ESU, and that pulsing rapid on and off allows for interval tissue cooling. And a lot of devices have audible signals that tell you the vessel seal is adequate. So what are the best practices? Definitely no tension. Let the instrument do its job. Keep the jaws clean. Never activate with coagulum that's built up on the inside of jaws. We saw that we need tissue compression for coaptation or vessel sealing. So if you have a char that's built up, you don't have that current flowing through your active electrodes to seal the vessel. And be careful, if you're sealing a 7 millimeter vessel, that's pretty big, that's probably the size of your finger, you really want to be careful that there's no calcification in the vessel because it can affect the current going through that vessel. So here's just a quick example of thermal spread. So this is just a piece of ham, and we have a FLIR thermal camera. These marks here are about 5 centimeters apart. And this is, since we're in America, we use Fahrenheit, so this is in Fahrenheit, so it gets pretty hot. So anything above probably about 200 Fahrenheit, and we can see here, that's tissue death occurring around the instrument jaw of an advanced bipolar instrument. This is a cold piece of ham, so when we're cutting through this, we see with the FLIR thermal camera that we have tissue death occurring around the jaw between 1 to 3 millimeters in width. So one of the last slides here, it's a really good way to compare devices. So if you're in the operating room, should I use a monopolar device? Should I use an advanced polar device, an ultrasonic device? Or now we actually have advanced cautery devices where actually the tip of the instrument actually heats up and then cools down very rapidly. So there are advanced cautery devices out now. So when you look at thermal spread, they're all about the same. You can get direct coupling with monopolar where you pick up your forceps and you want to do intentional direct coupling. You can touch your forceps. With the advanced bipolar devices, you can't do that. And please don't do that with your ultrasonic device, because ultrasonics, we'll hear with the next lecture, will heat up very, very, very hot, and you don't want to be holding that pair of pickups and heating your hand up there. You can get capacitive coupling with monopolar devices. Usually we don't see that with advanced bipolar devices. Alternate site injuries, less common because you're watching the tip of your instrument with the advanced bipolar devices. Inadvertent activation can happen with any device. Direct thermal spread, usually not seen with advanced polar devices, but it can happen. And definitely current leakage through the cord. So in conclusion, I think it's very important to understand the fundamentals of surgical energy in the operating room, and it's everybody's responsibility when you use different instruments, your monopolar devices, your advanced bipolar devices. You need to choose the right energy tool for the task at hand. And once again, very important concept that we're going to repeat over and over and over. Tissue death occurs at 60 degrees Celsius. Allow time for your active energy source to cool before touching any other tissue. Thank you very much for your time.